I usually give just a few minutes for those of you that are joining us today to be able to come on once the webinar is live. So we're just going to give an extra few moments here. Okay, we'll go ahead and get started. I'm Dr. Marnie Peterson, and I'm the outreach coordinator at the Center for Infectious Disease Research and Policy. It is my pleasure today to do some introductions and welcome all of you to a live roundtable webinar. So it's a very special opportunity where you've got quite a group of experts here today to speak about current trends, future opportunities in antimicrobial stewardship through innovations in diagnostics is where we're focused today. Just to introduce the speakers that we have today, we have Dr. Romney Humphreys. She's the Director, Division of Laboratory Medicine at Vanderbilt University Medical Center, a lot of experience in the field of diagnostic innovations. Dr. Ritu Banerjee, she's a Medical Director, Pediatric Antimicrobial Stewardship Program, also at Vanderbilt University Medical Center, works closely with Dr. Humphreys. Dean Pettigrew, Dr. Melinda Pettigrew, she's our Dean and Mayo Chair in the School of Public Health at the University of Minnesota. So we're very pleased to have her there as well. The Center for Infectious Disease Research and Policy is under her umbrella. And then Dr. Elizabeth Hermson will be joining us. She's our guest moderator today. She's currently Senior Medical Director of Launch Excellence at Pfizer. So she'll be helping to ask questions to our panelists, coming from her perspective of having been an antimicrobial steward for a very long time and having some global outreach efforts in health literacy as well across her career. So with that, I'm just going to go through some logistics. I'm going to talk to you a little bit about our CE. I'll give you an overview of the fact that this is a series of webinars. We've had 2 other webinars, so I'll give you a little bit of background, because if you have not viewed those yet and gone and obtained your CE, that would be good for you to do as well. So go ahead, Elise, if you can advance my slide for me when you're ready. All right, this is part of our series. I talked about the introduction. The Q&A will come after I've finished with my few slides. Should only take a few minutes. And at the end, just so you're aware, we'll provide the details of how to go collect your CE from being a part of this live webinar today. So go ahead, Elise. We are offering CE continuing education, and we're able to do this as a part of an educational grant we did receive from bioMérieux. So because of that, all of our speakers, our program planners have provided disclosure statements, and these are readily available through a link that we will provide to you in the chat box on the CIDREP website. And also the slides will be made available to you as well. So you'll be able to click and view consultantships that some people have. Obviously, I mentioned that Elizabeth Hermson is an employee at Pfizer. So just so you're aware of the other extracurricular activities people are involved in or their employment. Next slide, please. Okay, so this continuing education credits 1.25 hours today. We're offering CE for pharmacists, ACPE, and physicians and nurses, AMA, PRA. To achieve this, you'll watch this webinar. Your information will be provided to the CE provider, so they'll know that you registered and watched the webinar. And all you have to do is complete a survey within the next 30 days. So in August, you complete this, so you're going to receive your CE credit and you'll receive a certificate by email. Pretty easy. So please don't forget to do this. Okay, so quick review of past webinars. If you weren't able to join before, we've got a couple speakers back. So the very first webinar that we had, and you can advance the slide, Elise, is Romney Humphreys and Dr. Ritu Banerjee spoke in webinar 1 and really talked about current trends in antimicrobial stewardship. And we're speaking a little bit about novel approaches to diagnostics as it pertains to blood specimens, the clinical impact of some of these novel technologies, impact they're having now, the impact they may be having in the future, And then what do you do with this data? You have innovative analytical tools. What type of post-analytical innovations do we need to improve our antimicrobial stewardship efforts? So basically meaning as the analytical tools are developed, the stewardship efforts need to develop as well. So you're not left behind, you're utilizing these tools to best improve patient outcomes. This is the focus of this webinar. Elise, go ahead and advance. So I show this slide. This is from your slide, Dr. Humphreys and Dr. Banerjee. This is an image from the webinar. And it really talked about the pre-analytical piece. What tests do we deploy? What ones do we make available? What do we test for? Then the analytical tools that are being developed as we speak now, and some of the ones that are currently coming into our clinical diagnostic laboratories today. The more rapid results are now available. Is it useful? How do we best use that data? And then post-analytical utilization of all this data. How do we best support new breakpoints, reporting, and the types of interventions that will be important? We're going to revisit some of this with some questions in this webinar. And if you also have questions, please feel free to send those to our speakers, to our moderators through the Zoom chat box or the Q&A feature. Really important piece that we're going to talk a little bit about in our Q&A session. So the takeaways from this webinar were related to rapid blood culture diagnostics were increasingly available. They have great potential to improve time to optimal therapy and patient care. There are some studies that demonstrate improved clinical outcomes using rapid diagnostics. And it is maximized, of course, when implemented with appropriate stewardship. And that's the topic today that we'll be discussing. And there's the need for more research, implementation research to optimize and integrate the rapid tests into clinical practice. We've got gaps, we've got holes. How do we approach that and fill those gaps? Webinar 2. All right, this is Dr. Robin Patel and Betsy Wonderly-Trader from CARB-X, and Dr. Patel is from Mayo Clinic. In this webinar, we focused on phage susceptibility testing, and then from there, the innovation piece that CARB-X is interested in as they're building out their diagnostic antimicrobial vaccine portfolios and what they're focused on and how they deploy their resources. So the reason we focused on the phage testing susceptibility is that is also an innovative diagnostics test that's coming out, and it's very specific to the organism that people are infected with and selecting appropriate phage therapy, but there are a lot of gaps. Dr. Patel was not able to join us today. If you have any further questions on phage testing, we can obviously get those to her. We're going to focus a little bit more on innovation and some of the stewardship practices to support innovation as well as access as well that Betsy covered. But this was a very interesting webinar that I encourage you all to revisit, or if you haven't viewed, please go, especially from the phage susceptibility testing. Go ahead, Elise. Yeah, so this was the future opportunities for phage therapy that groups are looking at addressing. There's a session at ID Week this fall that's going to talk more about this, but just trying to understand the overall efficacy, the dosing, stability, pharmacokinetics to optimize this therapy. Those are discussed, and we really identified the gaps in that webinar. And finally, next steps for phage susceptibility testing, a need for standardized, reproducible phage susceptibility testing methods. We wanted to correlate the in vitro results to clinical trial findings. So are they predictable in the selecting of the appropriate phage cocktail? They may be clinically useful across many species of organisms. And can they be used to treat biofilm infections? Still under research and discussion. And Betsy Traynor-Wonderly's part of the webinar was related to her role at CARB-X and portfolio management of innovation. And really, she talked about this three-legged stool for antibiotic sustainability around, yes, you can fund innovation, but without access, it becomes particularly a problem because then you only have a few people that have availability to this. And without stewardship, your innovation is quickly lost. So trying to maintain accessibility matched with innovation with stewardship, which sometimes can restrict access or restricts access to that innovation to maintain that innovation long term, is very much a balancing act. And these are all three components of consideration for future innovation. And this is not just with antibiotics, it's of course with diagnostics. Can these diagnostics be deployed and utilized more at the point of care or low middle income countries? These are all of the questions that they're asking. Okay, and with that, these two webinars are on demand, available to you after this session at the Mad ID Continuing Education page at this link. And please reach out to us or them if you have any future questions on watching these and obtaining your CE. And if you take both of them, it's 2.5 hours of CE. All right, panel discussion. Let's move into that session. I'm just checking to see if Elizabeth has now joined, and she has.
Yes.
All right, Elizabeth Hermson is our guest moderator today, and she's got some questions for our panelists. And then I'm going to drop off, and I'm going to invite our panelists. At least we can probably just stop sharing the slides and let Elizabeth take over for future trends. Current trends and future diagnostic opportunities as it relates to stewardship. Thank you, Elizabeth, for joining us today.
Thank you, Marnie, and very happy to moderate this esteemed panel of guests today. So we'll start with a question to all of you. As you look back over your career, how have diagnostic tools changed over time, and what impact do you think they've had on antimicrobial stewardship?
Well, I can start. So I think that we've all probably been fortunate to be in clinical microbiology and infectious diseases at a time where there is a lot of innovation. If you look back to when I started my career, there were really one or two FDA cleared molecular tests for infectious diseases, HIV viral loads, and that was kind of like it. And so you fast forward to today where there's just a tremendous amount of options, both from a rapid diagnostic test and even tools to just speed up what we do day in and day out. And I'm thinking of mass spectrometry to identify bacteria, which has made huge changes to the clinical lab and how effectively we can do our testing. So it's been a time of a lot of change. And I think in sometimes the technologies have outpaced our understanding of how to best implement them. And so that's where we do really need more research, more implementation science on what do these new technologies mean for patient outcomes, because of course they are all much more expensive than the old school way of doing things.
Thank you, Romney. Melinda or Ritu, you want to add anything?
Yeah, I can piggyback on what Romney said. When I started in clinical medicine, I'm a pediatric infectious disease physician. So in taking care of children, we had influenza antigen and RSV antigen testing that we used in our clinic, but really nothing else. So now if you see what we have in our clinics, we have multiplex molecular assays to look at 20 plus respiratory pathogens. And we're getting results in, minutes or hours rather than days, which we were waiting for results in the past. And so the implications for stewardship are tremendous and very positive in that, for example, I can withhold antibiotics in a patient if I really think in the clinical context, the detection of a virus means that that's the etiologic agent of that child's febrile illness. And then on the inpatient side, because we've speeded up how quickly we can identify organisms from blood cultures and even speeded up how we can get susceptibility information on blood cultures, I can change from empiric antibiotic therapy to targeted antibiotic therapy for what we know the pathogen is and what it will be killed by much more quickly. So in that respect, diagnostics really support more targeted antibiotic therapy and withholding antibiotics when you don't need them. But on the flip side, there is definitely with this, you know, the amount, a number of FDA cleared tests that we have now, there's definitely, I think, overutilization of many of these tests, in which we can talk about in more detail. And that, on the flip side, might lead, you know, to overuse of antibiotics. So in a way, antibiotic stewardship now has become diagnostic stewardship as well. So it's been very interesting for me to observe this change over the years.
Okay, great. And I'll jump in and add to that. And we all know and think about diagnostics for clinical care. And I think about diagnostics also for research and for surveillance purposes. And one of the things that's really excited in the next wave is really all these advances in molecular tests and whole genome sequencing, metagenomic sequencing, the amount of data, the amount of information that we have access to. We're using whole genome sequencing to track foodborne outbreaks. There's an explosion of information with metagenomic sequencing on the identification of resistance genes. And we've gotten really good, I think, better at capturing what the bugs are resistant to, but sometimes that doesn't tell you what you can treat them with, right? And so there's so many resistance genes, and just keeping up with all this information is a big challenge. And as Ritu mentioned, there are these trade-offs, right? Because there's so many things have changed, and then there's still culture, which we were doing 20, 30 years ago. And sometimes culture provides anti-susceptibility testing or antimicrobial susceptibility testing, and there are trade-offs with some of the molecular tests. You can't tell whether the bug's alive or dead. You're looking at DNA sequences. So there's still a lot of questions to be answered, but it's a really exciting time to be in the field.
Thank you all. Thank you all for those insightful answers and sharing your experience over the years. All three of you kind of alluded to health system readiness and how ready are we to adopt these emerging technologies that are coming out in the diagnostic realm. So do you have any thoughts about what we can do to not only accelerate adoption of these tools, but accelerate appropriate adoption? Because again, all three of you also alluded to sometimes we are implementing these tools, but we don't necessarily know how best to use them. This is a question to the whole panel as well. Any thoughts around that?
Yeah, I think it's a really interesting question. Sometimes implementing new technology is easier than revising and refining, the tried and true methods that we use. And so what I mean by that is, if you take a look at antimicrobial susceptibility testing, one of the most impactful things a lab can do is keep up to date with current interpretations. These are, it's an evolving field, right? The more we learn about the bugs and their resistance mechanisms and the drugs and patients, we have to refine these things. But we know labs really struggle to make updates to those. And so that's, one area where I think often it's sort of the lab on its own, maybe with help with stewardship for some support, but it's really a lab type activity. If you compare that to a brand new multiplex PCR where there's a sales team and there's support and there's, a lot of, momentum around getting something like that implemented. And sometimes it can be easier to implement these newer technologies. But what the worry is that you lose sight of the really basic innovations and changes in kind of the status quo testing. One thing we do at Vanderbilt whenever we implement a new technology is we're very thoughtful about restrictions and what is the appropriate use case of that. And we do a lot of work with our electronic medical record system and the ordering end to kind of reinforce those. That being said, it drifts over time. It's actually kind of fascinating to see how it drifts over time. And so it really is a full-time job to keep on top of that and make sure that the technology is still being used for the appropriate indications, that there's no unintended consequences to the use of the technology. And to Ritu's point, I think that's tied so closely with stewardship, with antimicrobial stewardship. And so I think more emphasis on that kind of arm of antimicrobial stewardship may help institutions and hospitals get resources to do that, and make sure that those things are not only being implemented appropriately, but also being maintained appropriately over time.
I think another thing that might help adoption of newer technologies and appropriate adoption for populations where you think certain tests might have most benefit is if there's data that suggests which populations or during what respiratory virus season is certain testing indicated or not. Incorporating that into society guidelines, national guidelines, or institutional guidelines might be helpful. I mean, typically we've been slow to incorporate use of diagnostics into a lot of our clinical practice guidelines in infectious diseases, but IDSA has a diagnostics guideline that was just updated this year, and there's also a document that has some recommendations about which respiratory tests to use in what settings and what patient populations. That's also was written by the IDSA Diagnostics Committee. And I find those to be helpful, and that can inform institutional guidelines that then the stewardship team can work with the laboratory to deploy the test kind of following those guidelines.
Thank you, Ritu. Melinda, do you have anything?
Yeah, just to build on what Ritu was saying. I mean, so antimicrobial resistance is a global problem, but the epidemiology is so local. And so the needs are really going to differ based on the specific community and based on the specific health system. And you really need good surveillance data to, pinpoint what tests you need and in what population. And the guidelines can be really helpful, but as Ritu said, they're slow, right? You need good research on patient outcomes. You need good guidelines, and that all takes time. And these tests are being developed so quickly. And so, more support in prioritizing the guidelines so that we can get that information out in a timely fashion and that people have access to those, I think would be helpful.
But I will say it's all interlinked, right?
Yeah.
So the guidelines can only be informed by the data that's available. And if, we're really good at analyzing the analytic performance of tests, but we're getting better, but we still don't do a whole lot of looking at the clinical performance of these tests. And so I think you need to have those studies to then inform the guidelines to then, get that out there. So more work on that front, I think, is really important.
And Romney, so building on that, Marnie gave a recap from your lecture about the 3 different phases, the pre-analytical, analytical, and post-analytical phases. You just mentioned the analytical phase. In your opinion, which of those 3 phases do you feel like is the most lacking or least informative?
Yeah. I think it's the 2 ends, right? So the pre-analytic, the stewardship of the test before you even order it, is that the right test? I think right now, many institutions are suffering from blood culture shortages, and it just really reinforces with a very bright kind of underline how important making sure that blood cultures are ordered on the right patient population to conserve these precious supplies that we have now. And it's been fascinating for me. I haven't really given a ton of thought to blood cultural utilization at our institution, but as you start reviewing cases, you're like, man, this should have never been ordered, right? And so I think really a lot of effort and focus on that, which again takes a lot of time and focus. The folks at Johns Hopkins have done a fabulous job of this, and so there are guidelines out there that I point people to. So I think on that front end, and then on the back end, right, it's that, okay, you have your result. How do you deliver that result to the end user so they know what to do with it and what the most appropriate action is? And that's where, on both ends, such an important thing to have really close partnership between antibiotic stewardship and the lab, and, infection control too is another group that often gets very involved in these.
Thank you, Romney. And Ritu, I'll go to you next. Romney, you just mentioned once you have the results available, getting those to the providers. And obviously, interpretation of the results is an important aspect of that. And so one way to expand the impact that diagnostic tools can have, particularly on antimicrobial stewardship and the appropriate use of antimicrobials, is making sure that we're empowering healthcare professionals to utilize those data. So Ritu, how do you expand information around the diagnostic tools in your institution and interpretation of those results to nurses specifically, and then also consideration of other members of the healthcare team?
Yeah, that's a great question. I'm really glad you mentioned nurses because they spend the most time with our patients throughout the day. And they really know what's going on with the patient they're caring for. And I don't think we in the stewardship world in general do a great job of incorporating nursing or other health professionals who are non-physicians or non-pharmacists into our stewardship activities, but we should be doing that. So for example, nurses are often the first people to say, their respiratory secretions are different. Or a physician might say, maybe we should get a respiratory culture because this patient had a fever, but the bedside nurse might be able to say, but the secretions aren't different and they're actually weaning on the ventilator and there's nothing going on the respiratory side for this patient, So we need to rely on them, I think, much more in terms of providing some guidance about, do we really need to pan culture that patient with fever? No, they might be able to point us in the right direction of where they think the problem might be. The other issue is how to collect the specimen. Often our nurses are the people who are drawing the blood or the urines or the respiratory cultures. And for example, if there's not respiratory secretions to culture, they should not be doing a saline lavage to get enough specimen to send for culture, right? Likewise, they should not be drawing blood cultures from urine cultures from Foley catheters that have been in there for days, right? And in pediatrics, we don't like bag urine specimens. We like catheterized urine specimens. All of these things are where our nurses can partner with us on the pre-analytical, like how do we get the test correctly on the right patient? And then I think interpretation of the test is really important. Nurses spend a lot of time talking with families and patients. And the nuance of when is a culture clinically significant versus when does it actually just represent contamination or colonization and we don't need to treat it. That's a nuance that we struggle to actually communicate that effectively to the public and to our patients, but I think nurses could be allies in that discussion with patients and families.
Thank you very much, Ritu. And you did a really nice job laying out how nurses really play a role across all three of those phases that Romney mentioned in her first webinar. And so the issue that you bring up about considering how the specimens are collected, Romney, I'll come to you for this question. We've actually had multiple questions from the attendees about collecting from non-sterile sites or issues with like clean catch, for example. How do you feel like these issues impact the diagnostics, antimicrobial stewardship, and antimicrobial use? And what might we be able to do to improve the outcomes associated with these types of specimens?
Yeah, I mean, I think it people have heard this adage forever, but it's garbage in, garbage out, right? And so if we get a poorly collected specimen, then there's really nothing the lab can do at that point. And so I think that first off, really good education on how to collect, a clean catch urine. How should a patient do that? How is their education to all levels of patient? If it's, to Ritu's point, a patient with a Foley catheter in, that's that's really not a urine that we should be collecting to culture. And so all of these levels really need to be looked at. It's inevitable, and I'll air our dirty laundry. About 35% of the urines that we receive in our lab are contaminated with urogenital flora. And I think that's pretty standard. Like, imagine that's like 30% of all the urines that are collected poorly. And we try to be very, very strict about whether or not we are going to do any identifications or susceptibility testing on what grows. I will say there's an awful lot of pressure from clinicians to the lab to go ahead and work up everything in that culture. A lot of pressure. And you can understand their perspective. You know, if you have a patient coming in for a procedure and they live out of town and this is the only urine you have, and it, you know, but if we just at the upfront place got a good sample, we could avoid all of that drama. So I think it's twofold. It's getting a good sample, and that requires a ton of collaboration with nursing, to Ritu's point, other groups like physician assistants, anyone else who's involved in that process, and ongoing education to really reinforce the importance of that. And in my experience, nurses want to do the right thing for their patient, right? If they know the risks associated with collecting a poor sample, they would never do that, right? And sometimes, though, there's this lore that develops over time on how to do something that may or may not be right. And so it's, you know, correcting those habits. And then on the back end, the lab really does need to be strict with their policies on rejection of samples and reporting things out as contaminated if that's the case. But it is a tough dynamic, and having lab leadership and institutional leadership to support those policies is really key.
Yeah, thank you, Romney. And that's a role that the antimicrobial stewardship team can really play as well, in terms of that ongoing education and the importance of following those policies that are in place for appropriate specimen collection. Melinda, I'm going to come to you because earlier you made a comment about surveillance and the importance of understanding that antimicrobial resistance is really nuanced to the local population. And so what do we know about how drug-resistant infections impact different patient populations? And do you have examples that you can share with the group about where we have more robust data versus where data are quite sparse?
Yeah, thank you for that. And so I think we know that certain groups have higher risks for drug-resistant infections, individuals who are immune compromised or who have underlying medical conditions, diabetes, sickle cell, those types of things. I like to think a lot about health inequities, and the CDC is doing a lot of work in that space. And so there are a lot of reasons why certain groups might have higher risk for antimicrobial resistant infections. And this could be due to social determinants of health, access to care, their jobs, the frequency with which they travel to different places. There's a lot of good work being done in this space. So the CDC has the emerging infections programs, and they partner with local state health departments. There's the National Healthcare Safety Network, and they track data. And so we're starting to learn. The data's coming out. So we know C. difficile infections have a higher incidence in communities with lower income and high proportion of individuals who are foreign born. With MRSA, higher rates in individuals who are Black, and this is likely due to social determinants underlying medical conditions. There are differences in antimicrobial prescribing patterns. So these data are coming out. There are still gaps in it. We just published a study that just came out last week in Clinical Infectious Diseases. And here I think about the evidence base, and it's important for people to be aware of how the studies are done. And so one of the things that we looked at was strategy trials for antimicrobials to treat Staph aureus infections. So for example, this is a space where we know there are large health inequities, and there's been changes in FDA guidelines about representation in clinical trials. There's also been work from journals and NIH about funding clinical trials. And we wanted to see, has this changed over the last 20 years as the epidemiology of drug-resistant infections has gone up? And what we know is that these trials aren't enrolling in a representative fashion. So for example, women seem to be recruited quite well into these trials. And what we did was we calculated a participant to incidence ratio. So we looked at the subgroup who was recruited into the trial and divided that by the percentage of disease in that group. And if it's less than 0.8, they're underrepresented, more than 1.2, overrepresented. And what we realized was only about 80% of studies even report the demographics, racial and ethnic demographics of individuals in those groups. And fewer than closer to 20% even produced ethnicity data. And so there's a lot of missing data. We learned that Blacks and American Indian populations tended to be underrepresented in trials. And Hispanics were represented when they were recruited, but most of the time, and only 20% of trials, was that ethnicity data even reported. And so just to be aware of who's in, and that will impact generalizability of these findings. So I'd say that's a gap. The gap is in the evidence base. There's also gaps internationally. So surveillance is less robust in low and middle income countries. Access to diagnostics, those types of things. I've seen statistics that only 1% of primary care clinics in low and middle income countries actually have diagnostic capabilities. And so the WHO is doing work in this space. They're starting to do surveillance as part of national action plans, but huge gaps in just describing the epidemiology and the extent of the problem internationally.
Yeah, thank you very much for that, Melinda. I'm actually working on a paper right now, a meta-analysis looking at antimicrobial resistance in refugees and asylum seekers. And that's another population where there really is just a dearth of data in terms of the antimicrobial resistance that they're carrying, and also of the host country versus the country of origin. So another population to consider. And when you have particularly large wars like the war in the Ukraine, with a lot of refugees going to countries like Germany with very different looking resistance patterns, and the implication that that might have on antimicrobial stewardship and empiric treatment therapy, it's really interesting to consider that. So thank you for that answer. And I think I'll take a quick pause. We have some more prepared questions, but I'll pause now to ask Elise or Marnie, do we have any questions coming in from the live audience?
Elizabeth, we had a question, and I don't know on your background or history, around opportunities for nurses to get more training and certification in antimicrobial stewardship to become more of a part of the team, for your stewardship team. Rami or Ritu, do you have experience?
I don't know, but we certainly have a certification for nurses to become infection prevention experts. So it seems like a fabulous idea that we should be doing that for nursing expertise and stewardship as well. Yeah. Perhaps others in the audience or on the panel know more than I do.
I don't know, but I agree with the point.
There's I would direct the person asking this question, and specifically I want to call out Elizabeth Monsees. She's a nurse that's gotten her PhD and is conducting research. Forgetting now where she's located, but she's been a part of
Kansas City. I think she's in Kansas City.
She's in Kansas. Okay. She's very much a leader in this space. So I would direct you to her work. And if you're interested in further follow on, I bet if you reached out to her, she would respond. So she's a leader for nurses in stewardship. Thanks, Elizabeth.
Thank you, Marnie. Okay, we'll go back to some of the prepared questions. So we've heard a lot of comments from all three of you today about the utilization of the diagnostic tools that we have, and potentially looking, Romney, I think it was you, looking at, because of the blood culture shortage, looking at the utilization of blood cultures in the institution. So just thinking about how important it is that we're employing diagnostic stewardship in addition to antimicrobial stewardship. And this is a question to Romney, and the whole panel can comment as well. Are there any new diagnostic metrics that you think we need to enhance both diagnostic and antimicrobial stewardship efforts?
Yeah, so I think that we haven't quite landed on the most appropriate metric. I think a lot of what we look at is antimicrobial use, which is really valuable, right? There's no question that's valuable. With the understanding, of course, that if you optimize antimicrobials as quickly as possible, all of those other clinical outcomes will follow. That being said, looking at kind of more blunt measures of outcome like mortality, like length of stay, things get really muddy when it comes to the diagnostics, right? Because there's the test, and then there's somebody receiving the results of that test, and then they need to act on it. And so it's a little bit more tricky than, for example, giving a antimicrobial where there's a bit of a better relationship. And in even that, we know with antimicrobials, it was really hard to measure outcomes with those. So I do think we need some more innovative methods. I know there's a lot of work at ARLG, as an example, looking at alternative outcomes like desirability of outcomes, ranking of patients. And I think that's all really valuable. The trick with that, I think, is translating those outcomes so that they're understandable by hospital administrators and by other people who might look at them and not quite understand what's going on there. But yeah, I do think so. And the other thing I would say is we really do need to also look at how we break out of our traditional antimicrobial susceptibility test, right? So we're so wedded to that minimum inhibitory concentration that we get. But as we look to newer technologies, it's all about the resistance genes or the resistome if you're doing whole genome sequencing. And how does that correlate to an outcome? How does that correlate to an antimicrobial dose? And it's really tricky to know, but we do probably have to break out of looking at those types of MIC defined outcomes. And a good example is something that Marnie mentioned at the beginning, which is how does that apply with phage, right? Like we don't do an MIC test for a phage. So how do we then measure susceptibility, and how do we then measure outcomes? So I think we have a lot of work to do. But the good news is that there are a lot of people focusing on this, and it's kind of a fascinating area of research.
Thank you, Romney. Does anybody else have anything you want to add about metrics? Ritu, it looked like you were moving.
Yeah, I would just add that I totally agree with Romney, but I think the main point is that we've got to move beyond just test performance, right? Like sensitivity, specificity, positive predictive value, negative predictive value, but it's more like, does implementation of the test ultimately improve quality of care, however you want to measure quality of care? And I think a component of that, which is really hard to measure, is cost effectiveness, a cost analysis, because that's what hospital administrators will understand and will care about. And so, all the downstream benefits of some diagnostics on infection control, reduction of, secondary hospital-acquired infections, et cetera, need to be also somehow considered in these analyses. And that's hard to do, but they should be part of the equation.
Yeah, and so, we're talking about a lot of different potential data points that need to be considered when thinking about diagnostics and antimicrobial stewardship. And so, Romney, I'll go back to you. Do you see a role in artificial intelligence, or AI, in helping to optimize diagnostic data and antimicrobial stewardship outcomes, and specifically in real time? So not only, integrating all these complex data points and data sources, but doing so in real time to inform better clinical decision making.
Yeah, absolutely. I mean, if you think about it, there's so much data in the medical record, And I think I went to some talk and they talked about like how many different data points the human brain can like process at one time. And it's like 5 or something very small. Whereas if you look at using artificial intelligence and predictive models, you may be able to become a bit more sophisticated even before the diagnostics are available, right? So what is the appropriate empiric therapy for this patient based on the model that's generated at your own institution? That being said, I think that the tricky thing with AI is it all depends on your training data sets. And those training data sets are probably very regional as far as what is most predictive for your individual patients. And you know, when we talk about antimicrobial resistance, we live in this global a world where we have patients who are traveling from other countries where the types of bugs and the types of resistance that they see are going to be completely different and probably not captured in, like, for example, the Vanderbilt training set. And yet that patient may very well show up at our hospital and need care. So it is exciting, but I think there's still a lot of work to be done to really prove out how this can be implemented and how this can be maybe put into a risk stratification type model based on all of these data points that we do have available to us, but we just probably aren't harnessing to their full potential.
Yeah, thank you. Thank you for that. Melinda, I'll come to you because I've seen a lot of interest in using artificial intelligence from a surveillance perspective and trying to look at, for example, you mentioned the lack of data in LMICs. Is it possible to potentially predict what antimicrobial stewardship or antimicrobial resistance patterns would look like in some of those countries where we don't have surveillance data through AI? Do you have any thoughts on that?
Yeah, I mean, it's just to bridge off what Romney said. I think there's tremendous potential, but it really is based on the existing data set that you're using and what the models are trained off of. And so there are people doing this work at University of Washington, for example. And it's just important to keep in mind where the data are from. So often the data that are used for these training data sets might be from one primary care site in Nigeria, and it's a huge country. And so I think there's a lot of power with this. And as we learn more, I think these models will become better and better at predicting. And we just have to be mindful and understand what data are in the training sets that are being used to predict. But I do see a great amount of potential to this. And we can get information for places where there's not active surveillance. And so I'm excited about it and also cautious. We don't want these models to exacerbate existing inequities.
Right, right. Marnie, I see you came on camera. Do we have another question from the live audience?
We do. We have a question related to diagnostics reaching further out from the inpatient care site. So outpatient long-term care facilities, those, and I'm thinking long-term care facilities as well, because sometimes those the individuals that can then enter into the hospital, and how is that data tracking with the individual and connecting? So the question is, you know, how much is this being tracked? How robust is the data? Are the diagnostics being used appropriately? And are we missing some data there because they use a lot of antimicrobials? That's a synopsis of the question, I guess.
I'm happy to try to tackle that first, but
Yeah.
So outpatient antibiotic stewardship and diagnostic stewardship is a little bit like the Wild West, because as the questioner has mentioned, especially for a lot of clinics that are not part of larger health systems, it's harder to get just the baseline data of how or what you're using, what tests are being ordered, but somebody must have that data somewhere. If you're not, for example, our clinics, we are fortunate, we're part of a larger health system. We are able to track what antibiotics are being used and potentially overused in these clinics, in what conditions, and what diagnostic testing is potentially leading to that. So for one example, we have gross overuse of rapid group A strep testing for almost half of our sick visits. And so that leads to a lot of detection of group-based strep colonization and a lot of overtreatment of strep pharyngitis in viral infections. So that's an opportunity for us. My guess is it's probably similar in other locations. In long-term care, and I'm a pediatrician, so I shouldn't really be speaking about long-term care facilities, but I know asymptomatic bacteriuria is often cited as an opportunity to reduce testing and reduce antibiotic use. And if you're not part of a larger health system that can give you that information, health departments are now funded to look at statewide antibiotic use and even can get you, I think, at the facility level, some antibiotic use. That might be a good place to start.
Mm-hmm. It is the thing I'll comment on from a long-term care facility perspective is a lot of wound cultures, surveillance wound cultures, and like Ritu mentioned, urine cultures that get done. And I think there's like this interesting dynamic, right? So if it's a system that's affiliated with kind of an integrated healthcare system, then you probably do have a pretty good grasp on the data. And there is an opportunity through lab stewardship and through, reporting and through working with the ambulatory stewardship team to kind of help nudge people in the right direction. But a lot of these facilities send their lab testing directly to reference labs. And the model of a reference lab is very, very different than the model of a hospital-based lab, where, they're designed to meet client needs. And so if the client asks for it, generally the answer is yes, not, well, that's not standard, or that's not something that we would do routinely. And just from my own personal experience, one of the most challenging scenarios that comes up is when you're working in a healthcare system and you acquire one of these facilities, and people are really frustrated with the type of lab results they get back, because they're used to getting a giant long list and having ceftazidime, avibactam, as an example, reported on every single culture, or I really want my fluoroquinolone for my Staph aureus reported. And yet we would never do those things because that's really not best practices. And so all this to say, I agree. I think there's a ton of opportunity here, but it does require some incentives around this, which we're getting there, but we're not quite there fully.
Thank you, Romney and Ritu. So building on this outpatient versus inpatient discussion, Ritu, I'll come to you for this. The WHO has developed a set of assured criteria for point of care diagnostics, with assured standing for affordability, sensitivity, specificity, user friendliness, rapid and reliable performance, equipment-free operation, and deliverability to those in need. So I guess first, can you comment on which of those criteria have you found to be the most limiting in your practice in terms of the diagnostic tools that we have available? And how do those criteria potentially change or compare when thinking about inpatient point of care diagnostics versus outpatient point of care diagnostics?
Yeah, that's a great question. I think, and I'm very interested in Romney's take on this too, since we're in the same health system, but I think on the outpatient side, some of our clinics have been limited in the types of point of care testing they can offer just because of cost and workflow issues, and also the oversight. Like, there needs to be some QC, some training involved in actually being able to perform point of care testing, and not all of these clinics, many of them which are in non-metro areas of the state, are able to do that, and they don't have necessarily the workforce expertise to do that. The flip side is that outpatient testing should be low complexity testing, right? And the results should be ideally available before the end of a clinical encounter. So rapidity and speed is really important for that kind of testing to have the most impact, which is probably why we have so much group-based strep testing in the outpatient setting, because that's one of the few tests that are available, readily available, easy to perform, and with results available quickly. And people feel the desire to do something for patients who are coming into the clinic with us, during a sick visit. On the inpatient side, the speed that having a result within 60 minutes or a few hours is a little bit less important, right? And you're usually dealing with sicker patients on the inpatient side, and of course, most places like ours has a central laboratory where we could do high complexity testing. And so we don't necessarily care about rapidity as much as we care about accuracy and sensitivity of the test on the inpatient side. And I'll pass it on to Romney and see if I said anything wrong there.
No, I totally agree. I think that as we look both here in the US, but also in other countries, instrumentation is really hard for a lot of clinics to manage. And so if there's a different box for every point of care assay you're trying to run, that just becomes not tenable. You can't do it. And space, right? Space is a huge consideration in these. The only thing I would say is, that the group A strep is a great example. So we run an antigen test still. We have not deployed PCR to our ambulatory locations, largely due to cost, and that cost is the cost of the instrument. Even though it's relatively inexpensive, it's still more than those clinics can manage. And so you wind up with a test that's neither sensitive nor specific, which then results in just a colossal number of cultures being sent to the lab to confirm. And so I think in this instance, it's a question of, and should that test really be used to begin with, right? Like, is it really needed? And Ritu sees the pediatric side. I see the adult side as well. And probably just as many adults get a group A strep test in our system, which is just, there's no need for that. So I think, again, it goes back to stewardship. Just because you can doesn't mean you should, I think, is the motto of point of care testing.
Thank you, Rami and Ritu. And continuing to build on the outpatient discussion, Melinda, I'll come to you because you recently were part of a study to evaluate the duration of therapy in children with severe pneumonia. And I believe that the setting was in urgent care clinics, outpatient clinics, and emergency departments as well. So thinking about, do these kiddos need 10 days of therapy, or can we use a shorter duration like 5 days? So how did diagnostics impact the study findings? And what did the shorter duration, the 5-day duration of therapy, mean for the development of antibiotic resistance?
Yeah, that's a great question. Thank you. And this was a real privilege to be part of. And it was interesting recruiting kids to the Scout Cap study, actually, because there were so many people that had heard this, you have to finish your antibiotics, you have to finish your antibiotics. And there was this resistance to even enrolling and going shorter. The diagnostics was challenging with this. So the study design was set up so that we recruited kids on day 3 to 5. And so they were diagnosed based on standard of care in urgent clinics, in emergency departments in 8 major cities. And so diagnostics of pneumonia is really challenging, especially in children. The urine antigen tests don't work. There were no blood cultures done because these aren't recommended by the clinical guidelines for pediatrics in the outpatient setting. Chest radiography is also not recommended. And so the limitation was there were likely kids in the study that had viral pneumonias, but this was not necessarily a limitation because it was a pragmatic design and it really reflected the real world experience of what's going on and how community acquired pneumonia is being diagnosed in the communities. So that part was a challenge, but it was also, I think, reflective of the world. One of the things that was really fun with this study was we were able to look at the resistome. And so when you think about stewardship, it seems obvious, fewer days of antibiotics is better. and it will create less selective pressure on the resistome. But that hadn't actually been empirically tested. And we had the opportunity to use next generation sequencing, high throughput sequencing, to get a comprehensive look at the resistome in its totality. And we looked at both respiratory tract samples and gut samples. And we found that 5 days was actually better. So there was less resistance, significantly less resistance for beta-lactams, which made sense because we were treating with amoxicillin, amoxiclav. We also saw lower resistance with macrolides, and this shows how resistance can be linked, and multi-drug efflux pumps. So 3 different types of resistance genes were lower. And we also showed that resistance was lower for a longer period of time in the kids that had the short course antibiotics. And so this isn't ready to be rolled out in clinical care yet, but in the research setting, it was very helpful and interesting to get empiric evidence that shows that a shorter course is better. And so the trial showed that 5 days was superior than 10 days. And if you think about the 1.5 million cases of community-acquired pneumonia that are diagnosed, and you do the math, it looks like about 7.5 million fewer antibiotic days in the US annually, potentially, if this was adopted.
Wow, that's impressive. And the resistome data that you shared is really interesting as well, especially with all the increasing amounts of literature that's coming out suggesting the impact that microbiome changes can have on a whole host of other types of diseases, and thinking about these are kids and you're introducing those potential changes at such a young age and what impact might that have. That's really interesting. Thank you for sharing. One of the questions that we had that came in that was a really great question from a high school student, and this is a question to the whole panel. So this high school student asked, what can they do in their own community to help address the issue of antimicrobial resistance? And what would you say to this particular student or other individuals who might not be healthcare providers or laboratorians?
I guess I can start with that one. First of all, I think it's fantastic that a high school student is actually interested in helping out with this issue. I would say you can start with yourself and your close friends and family, and really just think about your antibiotic use. Not taking drugs that are sitting around in the cabinet, taking antibiotics only as prescribed. You can share the message with your family. And then beyond that, it's such a huge field. It impacts so many different areas. And so I think there's room to pick the area that you're interested in. If you're interested in antibiotic use in dental clinics, look there. There are 2 places that I would advocate for, but this is based on my own personal bias, is that there's a lot of movement in the anti-vaccine space, especially post-COVID. And vaccines are actually a wonderful tool to help the challenge of antibiotic resistance. So if you think even viral vaccines, if people are vaccinated, it's fewer visits to the healthcare system, fewer opportunities for empiric prescribing or inappropriate antibiotic use. And so really educating ourselves about the importance of vaccines and encouraging people to get vaccinated with vaccines that we know are safe and effective is one way to help. I also am interested in One Health. And so more communication between the different sectors. About 70% of our antibiotics are used in farming. And so having more communication between clinicians, veterinarians, we see MRSA in cats and dogs, and what does antibiotic use look like in the veterinary space? So having those conversations across disciplines is another area. But I think we need advocates across all these areas. So whatever they're interested in, I'd say go for it.
Thank you, Melinda. Ritu or Romney, anything to add?
I totally agree with Melinda. Start with educating your peers, your family, your community members in whatever spaces, forum you have to do that. One opportunity is World Antibiotic Awareness Week, which happens at the end of November every year, and it'll happen again this year. So that's when WHO, CDC, state health departments are getting that message out about the need for judicious antibiotic use, the need to conserve these precious resources of our existing antimicrobials. They're really getting the message out there. And young people, like the questioner, are much better than people of my generation at using social media to reach wide audiences. And so that might be also an opportunity.
Yeah.
Thank
The only
you.
thing I'd add is I think, I'd encourage young people to reach out in their own communities to learn more from people like Ritu or Melinda, reach out. We all love chatting. We're obviously passionate about this. And even at younger ages, I think there's a lot of data that shows the field somebody goes into is very influenced when they're sort of in the middle school kind of age range. And so one of the challenges we have, I think, in infectious diseases is people don't get a ton of exposure to that in their daily lives. So reaching out and learning more would be a great way to start too.
Thank you, Romney. Yeah, I was really excited to see this question as well, because it's just, it makes me excited to see younger generations that are interested in infectious diseases and what they can do to help address the problem. And one of the things that I usually tell people, and it doesn't matter how old they are, anybody can do these things. It's the 3 Ps. And the first is being proactive. And so that's doing things like Romney's talking about, reaching out, learning more, helping educate your family members and friends, being proactive in your discussions with your providers. If you are prescribed an antibiotic, do you really need it? Maybe they're prescribing that antibiotic because they feel like that's what you want from that particular visit. So that's the first P. The second is prescription only. And so, Melinda, I think you alluded to this as well, not sharing prescriptions, not saving your antibiotic prescriptions and giving them to a friend or a family member. And then the last one is prevention. And so things like staying up to date on your vaccinations, washing your hands, staying home when you're sick, general infection prevention measures. And those are things that everybody can do that help with antimicrobial resistance. Marnie, I'll go to you. Do we have any more questions from the live participants? I'm sorry, what was that?
There's one that just came in. I'm just reading it, but
I can speak to this a
Um,
little bit.
urine PCR testing.
Yeah.
Oh, great. Thanks, Romney. Go ahead.
Yeah. So there are a lot of companies, and we're actually working on a review on this space when it comes to urine diagnostics. And there's a surprising number of sort of stand-up labs that offer testing where they have very broad panels of microorganisms that they can detect in urine. And I think that the message is we're more sensitive than your standard technology. Well, of course they are, right? Because probably a lot of those things are growing, but the lab's not reporting it because it's normal flora or whatever. So I do think it is a big concern that these are being heavily marketed to end users. And it's entirely possible that for some patient populations, this is the right technology, but it's certainly not the technology for every patient population. And there's no clinical outcome data that really looks at the impact of these tests in a robust manner. And so this is kind of what I was talking about earlier about technology sometimes outpacing our understanding of how to implement it appropriately. So this is something that honestly makes me very frightened when I see it, because in some cases there's treatment guidance associated with individual resistance genes that may be intrinsic. And one great example is detection of a Klebsiella pneumoniae and a SHIV beta-lactamase gene. And the report says beta-lactam resistant, you have to go to a carbapenem. Well, SHIV is intrinsically found in Klebsiella pneumoniae. It's the reason they're resistant to ampicillin. So you don't need to go to a carbapenem. And yet, so it's like this overinterpretation of these data that we don't have great tools today to help end users understand. So I agree with this person. It's a little scary what's going on out there.
Thank you, Romney. So Melinda, earlier you mentioned your interest in One Health. And we had a question come in before the webinar about wastewater surveillance. And we heard a lot about wastewater surveillance during the COVID pandemic. So do you feel like there are opportunities to use wastewater surveillance to help address antimicrobial resistance? And what might be some of the pros and cons that should be considered when looking at these types of data?
Yeah, that's a great question. And I think we're not there yet. I think there's some potential, but it worked really well during COVID. It was helpful for identifying symptomatic and asymptomatic infections. They're using it at the Olympics. So this is a really timely question. So they're going to be tracking measles and polio. I think the challenge is that bacteria are far more complicated. And so in terms of the benefits, we can think that if there's an opportunity to capture silent infection, it might have a broader base in the community. So people that are outside of the healthcare system, you could potentially detect emerging pathogens and emerging resistance genes. It could be pretty quick. There's problems or challenges with normalization. So many of the bacteria we might be interested in, Enterococcus, Pseudomonas, they're in the environment, they might be in animals. And so that direct linkage to human health may be challenging. There's resistance genes that can be transferred between organisms, and so challenges in linking the resistant gene to the specific pathogen. So I think there's a lot of work that needs to be done in this space so that it would be helpful for surveillance purposes. We could also think about, I could see it being very helpful in a hospital setting or, tracking wastewater coming from a healthcare system versus in the community. If you focus on a hospital setting, that might give you timely information about pathogens that are circulating. But we really don't have yet the good quantitative metrics and the normalization techniques that we had with COVID. And the fact that some of these are pathobionts and in the environment makes it very challenging to interpret. So there's potential there, but we need to do a lot more work so that it's usable and interpretable and actionable.
Okay, thank you, Melinda. I know we're coming up on time here, so I'll close with one final question, asking each of the panelists to look in your crystal ball and take 30 seconds, so really brief answers. We've heard a lot of discussion today about how we have had significant advances in diagnostic tools, but some of that is outpacing our ability to keep up with those advances. So if you're looking in your crystal ball 5 years from now, where do you think we will be? What do you think will be the biggest innovation in diagnostics that we will know how to appropriately use? So 30 seconds each. Ritu, I'll start with you.
That's a really, oh my gosh, tough question. What my wish, on my wish list is that there would be an amazing diagnostic to help us differentiate viral versus bacterial infection. I don't know if we'll get there, but that would be top of my list.
Okay. Romney.
Yeah, I'm kind of with Ritu. I think that we've got a lot of tools to detect the bug, but not a lot of tools to help us understand the host's response. And, and so maybe to add to Ritu's, not just bacterial versus viral, but colonization versus infection would be amazing.
Yeah.
I don't know that we're going to have it or that we'll know how to use it by then, but that's the hope.
All right. Thank you. And Melinda.
Yeah, I was going to say exactly what Ritu said. Bacterial versus viral differentiation. I think the colonization versus infection is important. And I would also love to see us in a better place with whole genome sequencing and some of these genetic tests in terms of identifying resistance and also providing information on what we can do to treat these patients, because we can tell what they're resistant to, but not necessarily what they're susceptible to yet. So I think we'll be further along soon in that space.
All right, great. Thank you so much. This really has been a fascinating discussion. I have enjoyed moderating the session. Thank you to all three of you for taking time out of your schedules to answer these questions. And I hope the audience found this helpful as well. And Marnie, I think you're going to talk about CE credits now.